Good afternoon, everyone. Thanks for joining us. Thanks especially to Dr. Bennett and Krystal and others for putting this together. I'm presenting the very first part of a three-part series with several great speakers and experts in what they do on the perspective from the emergency department. So this is the front lines of the opioid epidemic and looking at some of the barriers and challenges we face in the emergency department. I'm an emergency physician. I'm also the Director of Public Health Programs in my department at Sidney Kimmel Medical College at Thomas Jefferson University in Philadelphia. So just quickly, in this part of the talk, we'll review some of the national and local data on substance abuse disorders and overdose, in particularly related to heroin and opioids. I will illustrate some of the issues we face by reviewing a clinical case from the emergency department of a single patient, and then really use that to discuss a multi-pronged approach to combating the opioid epidemic. And finally, I'll introduce and discuss the concept of peer support services that will lead into Brian's talk and then lead into the rest of the series. So all of us are aware that opioid has become an epidemic, opioid use, and certainly heroin addiction and overdose has become a significant public health issue. It's affected, really, it's increased across almost all demographic groups across the country. Closer to home in my state of Pennsylvania, we see a similar picture. It's really very rare areas that have not been touched by drug poisoning, and in particular you can see Philadelphia in the southeast part of the state. We are dark red, unfortunately, and it certainly has very much affected our city. On a whole, the state of Pennsylvania ranked 8th as of 2014 data in national rank for drug poisoning deaths, and the vast majority of that is from opioids, whether it be heroin or pills, but of those, vast majority is heroin. So closer to home still, in the city of Philadelphia, this is just an overview of the number of overdose and injury-related deaths in Philadelphia. You can see that the green line, which is drug overdose, has showed a marked spike really since 2012, but even looking back, starting earlier than that, had peaks and then went down. There was, when I first moved to Philadelphia in the year 2000, I don't remember if it was 2000 or 2001, but the city had the largest number of gun-related deaths. As of 2015, there were more than twice as many deaths from drug overdose in Philadelphia as there were from homicide. So shows just really how much it has affected the entire city. Looking closer at those drug-related deaths, you can see the dark blue line is heroin, and that too has, been increasing since 2011 or so, with a very, very steep rise. You can see the red line marks fentanyl, and there was a peak earlier in 2006 where we were seeing a lot of fentanyl, and fentanyl now we're seeing again on an uprise. In most cases, we're seeing it as additives to heroin, that users are not, those who are using heroin are not aware that there's fentanyl spiked product that they've been using. The other point of concern is the significant increase in combination of benzodiazepines such as Xanax or Ativan or Valium with heroin has increased, as well as cocaine is in there too. The two most concerning certainly are that we've been seeing is heroin and benzos together. So let's talk about just one patient, and I think that she's a good reflection on what some of us see. Amy was a 26-year-old female. She came to the emergency department with a chief complaint of, I don't feel good, or I feel sick, very nebulous, kind of nondescript. In talking to her and getting her history of present illness, we learned she's a 26-year-old female. She came in complaining of diffuse abdominal pain. She had nausea but no vomiting, some subjective fevers, but she hadn't checked her temperature. She just felt like she had a fever. overall the symptoms had been going on intermittently for the last few days, 3 to 4 days, but today it was worse, and so she came to the emergency department. No sick contacts, nobody else with similar symptoms, no travel or anything like that, and her last menstrual period was 3 weeks ago. The emergency department chart shows that her vital signs were pretty normal overall. Her heart rate was ever so slightly elevated at 108. But other than that, she didn't have a fever, her blood pressure was good, her pulse ox, how much oxygen there is in your blood, was 100%, so perfect. She didn't have any past medical problems. The only past surgical history she had was knee surgery when she tore her ACL in high school. In terms of her social history, she did report that she smoked cigarettes. She did report that she drank alcohol, but she denied any other drug use. So on her physical exam, she overall looked a little bit uncomfortable, but she wasn't in any acute distress. She had slightly dry mucous membranes. Her lungs were clear bilaterally, so no wheezing, anything like that. Her heart exam showed that she was mildly tachycardic, like we saw with her vital signs. Her heart rate was a little bit elevated, but otherwise fine. Her abdomen was soft, not distended. When you pushed on it, it was kind of like a little bit uncomfortable all over, but not localized pain in any specific area. On her back, she didn't have any flank tenderness or any pain over her kidneys. Everything else was fine, and neurologically she was fine. In kind of doing her exam, the doctor noticed that she didn't have any rashes, but she did have track marks in her on her arms, basically in the bend of her elbows on both sides. So this really gives us a picture that she had medical issues, that she was coming to the emergency department, and in doing her exam we realized that she actually was injecting, and she admitted to IV drug use with heroin. So, you know, the CDC really has put out a lot of information on this. This is a national crisis. And they described 3 ways of responding to the heroin epidemic, and really a tri-pronged approach. You know, the first is to prevent people from starting heroin. The second is to reduce heroin addiction, and the third is to reverse heroin overdose. And we'll discuss each one of those and how they relate to the emergency department, and how some of the sort of interventions from emergency departments across the country have really been doing this. So in terms of the very first one, reducing the number of people switching to heroin, there is a concern that the vast majority are switching from pills to heroin. And in looking through, there is really a wide range of how physicians or providers prescribe opioid pain medications. You know, in this illustration shows there are states that, like Hawaii, that have prescribed 50 prescriptions for every 100 people, and then there's other states like Tennessee that are almost 150 per 100 people, which show that there's more than 1 prescription per person. The state of Pennsylvania is somewhere in the middle, but it really kind of gets to the fact that there's wide prescribing variation. And I will say, you know, my entire medical career, in the very beginning, we were told in no uncertain terms that we always treat pain, and that was a part of addressing a patient's overall medical issues, is make sure to treat the pain. And the pendulum at that point was swinging the other way, where we were really trying to address pain. It became part of everything that we were doing. It became part of how we were engaged in terms of individuals as physicians, but also the hospitals were marked in terms of how well they addressed the patient's discomfort. So, you know, in this vein, now on a national level, we're swinging the pendulum the other way and really being much more cognizant of how we prescribe and judicious in our prescriptions. Emergency departments have always been significant points of access for patients across the country. We are termed, you know, the safety net of the system. What that begets, though, is that we tend to see things happening as they're happening, and because we're seeing, we don't have a specific patient population, we get it from the community. And so many years ago, emergency physicians were actually among the first to draw attention to prescription opioid abuse because we were seeing more and more patients coming into the department, not with necessarily acute pain issues, but more with chronic pain that had been getting prescriptions from other places and were coming basically looking for refills or really to address chronic pain issues. And places like Washington State were among the first to really shed light on the issue and try and address it for their patients with identifying safer prescribing practices. We have emergency physicians and emergency departments that have certainly been kind of lumped into part of the major problem in how many prescriptions we were giving out. This study by Nora Volko in JAMA several years ago looked at that same question and really came up with the same answer that I think a lot of us kind of feel, that emergency physicians may give out several number of prescriptions, but they're always for very short duration. And it's to treat an acute process. But actually the vast number of prescriptions and sort of that accounted for the number of pills that were being prescribed came from primary care physicians. Younger ages, it were sort of post-surgical or dental, procedural related. And then as people got older, it was more their primary care physicians who were treating it and became more of a treatment for chronic pain. In our emergency department, and in the city of Philadelphia, there was a group of emergency physicians several years ago that we all sort of came together. We were all seeing it in our different emergency departments that patients were coming in from as far away as New York City even, with chronic pain issues and sort of expecting or demanding refills or addressing chronic pain issues. So as a group, we kind of decided that really for the safety of our patients and the safety of our community, we should address it in terms of have sort of a more unified approach to how we were prescribing. And this is an example of the Jefferson Safe Opioid Prescribing Policy. We do this to not just keep our prescribing habits and processes in check, but also to be able to communicate with the patients, and sort of set expectations as well. So that was among the first. The city and other emergency physicians had been doing this, and it kind of informed the state level. And then as the pendulum, as I mentioned before, it started swinging, where we initially didn't have a lot of guidelines in terms of how we prescribed or how we approached pain issues, then we got a ton of information. So now, on the state level, Pennsylvania has issued guidelines for pretty much anything you can imagine in terms of how it would be the most appropriate way to prescribe. So going back to Amy, like I mentioned, she did admit to IV drug use. In asking her first exposure to opioids was after knee surgery, and she was given Vicodin. She didn't use it again until she was 21, and a friend just gave her a Percocet kind of for fun. And it was enough to sort of get her to start using Percocet. She moved on to OxyContin, also from friends, and then eventually she was buying it off of the streets. And she came to Philadelphia to experiment with heroin, also with friends, and went back to, she lived in the suburbs, she went back home, and she realized, she said to me, I never knew the dope in Philly was so much better. And so she would make frequent trips to Philadelphia specifically for heroin. So that last part of Amy's story is something that those of us in the city of Philadelphia see a lot. The heroin in Philadelphia is very pure relative to pretty much anywhere else in the country. We've had levels almost to 75% purity. And so what happens is a lot of people from outside of the city of Philadelphia come into Philadelphia to use. What then happens is that if they're used to a certain dose of heroin or they're used to taking so much, they come to Philadelphia not quite realizing that it's much purer. And so that has also affected the number of heroin overdoses. So naloxone And this is another aspect of what the CDC describes as really a way to combat the epidemic. Naloxone is an opioid antagonist. It's a medication that's used to counter the effects of opioids. It doesn't work on any other medication. So if you have Xanax in your system or benzodiazepines, anything else, alcohol, it doesn't work. It only works for opioids. It counteracts the depression of the central nervous system and the respiratory system. It's non-scheduled, but it is a prescription medication. There's no potential for abuse. It can be given intramuscularly, so like a shot in your arm or your leg, subcutaneously or intranasally. And the duration of action ranges from 20 to 90 minutes. So this is sort of a little map of Philadelphia, and this is just from 6 months worth of data from January to June of 2015, and the number of EMS reversals that happened in the field. So you can see there's only one area of the entire city where emergency medical services did not have to use naloxone to reverse somebody in the field. And then there's certain areas that are even higher. The Jefferson hospitals are in 19148 and 19106, so you can see where we, sorry, 19107, you can see where we are on that map. So the state responded really addressing the how the opioid epidemic is affecting everybody on the state level with two things. One was Act 139 and the standing order. So Act 139 made it possible for individuals to obtain naloxone and have the potential to reverse. Also gave access to first responders, not just EMTs who had always carried it, but also police and fire. And like you saw in that previous illustration, there was more than 1,200 overdose reversals in just 6 months. So that's more than 1,200 averted deaths, really. The standing order was issued by our Physician General, Rachel Levine, in October of 2015. That made it possible for people, any individual, to, in theory, walk into any pharmacy and ask for naloxone, and it would, the pharmacy could distribute it to them without a specific prescription. The standing order was basically a prescription from the Physician General for anybody in the state of Pennsylvania. When we did an evaluation of it, the one part of the standing order was that pharmacy participation was voluntary, and a few months after the standing order was issued, Prevention Point of Philadelphia and other organizations kind of looked to see which pharmacies were participating, and at the time there was only 8, and there was a lot of confusion. So another aspect was that some of us physicians, and we were kind of trying to get the information out to all physicians of actually prescribing naloxone to all of our patients who may be at risk or who had suffered from overdose in the past and had been reversed, but certainly those at risk, to also sort of act as a bit of social justice in that if we were writing a prescription, the pharmacy had to have a stock of naloxone, and so potentially more available for anybody else who was walking in and trying to get an understanding order. Part of what happened as a result of both Act 139 and the standing order were that there was an active encouragement for prescribers to screen and educate their patients, and then also, of course, to prescribe naloxone on the risks of overdose. It's now just exactly a year, actually, since it was issued. So going back to Amy, in her history, her personal history, her heroin use over a couple years became more debilitating. She did report a history of overdose that required reversal. She had been in rehab 3 times. She was no longer allowed to stay at her parents' home. She lost her parental insurance coverage when she turned 26. She was staying with different friends in Philadelphia and her hometown, which was in the suburbs. And 5 days prior to her ED visit, she watched one of her friends, or she was with one of her friends when they overdosed, and she couldn't be revived. And that was the impetus for her to try and cut back. And what she was trying to do was just sort of cut back or stop altogether. This slide sort of looks at how the opioid epidemic and opioid drug overdoses has really affected the emergency department. And this is, really the space in which I live. This graph actually is not quite, but almost the bulk of my professional career in emergency medicine. And I've certainly seen that upward trajectory. Of note and sort of the impetus for my work and being involved in this series and everything I've been sort of trying to develop is that last line. For each opioid-related death, there were approximately 12 hospital ED visits. So ostensibly there were potentially 12 opportunities to have broken the cycle or allowed a patient to access greater services for their addiction. So this gets to sort of the bulk of the series and the bulk of my efforts in recent weeks. The efforts to reduce heroin addiction and ensure access to treatment. So there are limited options for most emergency departments. We provide a vast array of services. We are meant to sort of live in the acute care needs. But things like addiction and a lot of mental health related issues, there are limited options from the emergency department. And it's many barriers, both within the emergency department in terms of what kind of services we have, what kind of capabilities we have, but also even just identifying the problem. It certainly happens that we see a lot of it. We are all sort of working fast, and we are working to address the needs of any number of patients at any given moment. But there is not as clean an access process for mental health services and addiction services as there are for more physical medical problems like diabetes and hypertension and heart attacks and trauma and all of the other things that we deal with. And so we may or may not identify addiction as being sort of the underlying problem. And then going on, of course, in terms of our capabilities of what we can do in the moment. That said, there are a slew of barriers, both also external to the emergency department, that when you do try, kind of get in the way, absolutely. So the first, I don't know if this is specifically our state related, but I suspect not. But one of the basic needs for access to treatment and addiction services is something as basic as having identification. So if you look at Amy's case, she was from the suburbs and she would come into the city. Many times we have patients who arrive via ambulance who are brought in. They don't necessarily have identification on them, and that's the first step. I mentioned Prevention Point is one of our harm reduction agencies in the city. Prevention Point, one of their major points of intervention is helping people get identification, and that's something that level of coordination is difficult from the emergency department, but certainly is a barrier to us being able to refer our patients. The second is residents. So in the city of Philadelphia, if you are a resident of Philadelphia or of Philadelphia County, you potentially have access to city services. But if you are someone like Amy or somebody else who's coming in from outside of Philadelphia and your permanent residence isn't Philadelphia, then you don't have as easy access to those city services. There may be private services that you could access, but that is a major barrier for many of our patients. Insurance status definitely plays a role as well. Treatment options and availability. Community behavior and behavioral health in the city of Philadelphia has worked over the last several months to years to really increase service lines, but they're still functioning at, the last I was told, I think it was about 120 to 130% of capacity. So there are, at the end of the day, there are still limitations, limited spots for treatment, and limited availability in terms of if it is available immediately from the emergency department. The coordination involved in coordinating all of the care, coordinating all of these needs, even just from this list, if it requires identification, determination of residence. But on the outpatient setting, in terms of being able to link someone and get them there and everything that goes into that is really quite extensive and can be beyond the capabilities of any emergency department. And finally, and certainly most importantly, is patient volition and engagement. So in the setting of Amy, she wasn't immediately reversed. She didn't just come back from a life-threatening event, but she was certainly in the process of, and she had kind of come to her own understanding that she really wanted to stop or try and stop her heroin use. But for patients that we reverse, in the moment, while we try and reverse them more gently than in years past, where it's not immediately putting them into withdrawal, there is, they may or may not be in the time and place to be ready to listen or talk to somebody about addiction services and things like that. And really maybe the emergency department and the way we function, at least the physicians and nurses, we may not be the best voice in that moment. We certainly try, but I acknowledge our limitations. So peer engagement has come out as a really great option and a good answer to a lot of our issues. These are just some definitions from SAMHSA. They define peers as someone who has experienced a behavioral health condition firsthand and is now in recovery from a mental health and/or substance use condition. Peer support is a mutual form of shared interactions in which participants seek to use their personal experiences to both help others and gain additional reinforcements for their own circumstances. And finally, peer support services is an intentional peer service that are services that are delivered by people who have received training and certification to provide these services. And certainly all of that together, but certainly a program in its entirety would potentially be an answer to a lot of our limitations in the emergency department. I apologize if some of this is a little small. This is an illustration or a graph from SAMHSA and in describing peer engagement. You can see a lot of the barriers that I listed are really in terms of how they evaluated peer services, addresses it both for patient factors and the system factors. So, overburdened providers or fragmented services, lack of emphasis on recovery, that may be, some of the criticisms of the emergency department, but also patient factors. And peers in the emergency department could really address all of these. My sort of impetus, as I mentioned, the data that shows how many times somebody has been in the emergency department before they overdosed, is really try to figure out a way that we can use that moment and maximize what we can offer in that time. So peer engagement certainly offers an ideal for linkage and coordination to overcome the barriers that we discussed. But as I set out to kind of try and think through a process that we could implement, there's a lot of questions on really what the ideal program would look like. And I think part of those questions and my sort of reaching out to Dr. Bennett and all of her expertise kind of led to this series of, or had a role in developing the series of, there are plenty of people doing great programs, and so it can help inform us. So, one of the questions is, what would be the qualification of peers? We know that they're trained a particular way, and they have an approach, but is it better to have a peer that sort of mirrors the population in your emergency department, or is it better to have somebody who's completely separate and so has a little bit of difference? In terms of staffing models, do we always have someone in-house in the emergency department, or do we have them on call? We see that there's very little rhyme or reason of when somebody will come to the ED in need of an emergent reversal. And so what we have to think about is how to maximize the services that we have at hand. And of course that is related, as is everything related, to how is it funded and how is it become a part of the services offered, if it becomes a sustainable part, if it is externally funded, and how does it feed back into the process? That's definitely, as the director of public health programs, that's a question I'm asked frequently in terms of emergency departments. It's always, the question is always about how can we really maximize our funding for this. So going back to Amy, on her ED visit, that time everything was normal, everything came back normal. And both Amy and the doctor recognized that what she was having were the beginnings of withdrawal symptoms. During her workup, she had received morphine to counter her pain, I think probably before the full extent of her heroin use was understood, but certainly to make sure that, you know, while something was being determined, she was made more comfortable. So by the time she left, she was no longer really in withdrawal symptoms. In discussion with the social worker, Amy was in a place where she really wanted help, but she was not a Philadelphia resident. She didn't have a driver's license on her. She didn't have insurance, and so there was no way to directly refer her to any services from the emergency department at that time. So she was discharged with an informational packet of resources around the city and specific instructions on where to go the very next morning for walk-in services. And I've done that many, many times with many patients, and it's probably the least fulfilling thing I do in terms of handing someone a packet of information and really hoping that they will engage in something, but knowing that the system is really complicated and really difficult to navigate. So looking ahead, you know, I mentioned that EDs are often limited in our abilities to provide for the full extent of services that align with what we know to be best practices. So really new strategies and novel approaches are needed for this. Peer engagement could be a really great answer to that. But most importantly, it's the development of collaborations between community addiction and mental health services, institutional approaches, and really keeping the emergency department as a key partner in that, because we really are we are on the front lines without any question, and people may or may not recognize how much we see or do in regards to the opioid epidemic. So again, you know, this is 3 ways of addressing it, but it's 3 specific ways that will require all of us in every specialty, in all parts of the country, really working and trying to work together to reduce the barriers that our patients and we have in terms of how best to help our patients and really address this on a national level. So happy to take any questions.
Thank you so much, Priya. We do have a question that's come in. How many social workers are available on each shift in the emergency department?
Just 1, and we don't have 24-hour social work coverage. I think it goes up until, I want to say 1 or 2 in the morning.
Great. So there's a comment that you know, this approach really is giving you know, pain relief to someone presenting who might have an opioid use disorder, and then sort of sending them on their way after that with some pamphlets and some resources. What response do you have to that sort of criticism of the program, and are there any other better approaches that you think could be used to better connect people in the warm handoff piece of the program?
Well, that's kind of the crux of the issue. That I think we all recognize that that's not ideal, but the issue is that there are very few alternatives. So, you know, my sort of quest to develop more services out of the emergency department and increase collaboration with addiction specialists, as well as, you know, build a warm handoff process with the initial step of potentially developing a peer engagement program that is very much to address all of those.
Great. Do any other states have shared hospital coverage for example, the approach used for foreign language interpreters?
I'm sorry, I don't understand.
I think what the question's getting at is the approaches that emergency departments use to better communicate with patients who there might be some language barriers. Are other states sort of doing, are there shared resources among the hospitals?
Each emergency department, we all have language services, and we use, whether it's in-person translators or over-the-phone translators. I'm not sure if that's a reference to sharing like peer resources. As far as I know, there isn't, at least in the city of Philadelphia.
Okay. Another question is, have you thought about giving out Narcan to anyone that comes into the emergency department on an overdose?
Yes, in fact, that we are just about to start it. We have made it a practice, certainly among the residents that are training in emergency medicine, because I'm the one telling them, but of discharging patients with a prescription for naloxone. It's been quite difficult to get just kind of a supply of naloxone to hand out, but we have now a supply that we can do that with, and that will be the plan.
Okay, I think we have time to take another question. What would be a good approach within hospital settings where contracts are in place for assessment services but there's no peer engagement?
So that is really what we're developing now, and I think we're kind of learning as we go. There hasn't been a peer engagement process in the emergency department at Jefferson, as far as I can tell. In terms of inpatient, when a patient's admitted for any number of reasons, there certainly at one of our hospitals, both of our hospitals really, there's access to an inpatient consult with psychiatry and kind of addressing it that way. But I think as we're developing this and as we're all trying to figure out other ways of increasing access and decreasing barriers and really making it that we have more services available to patients, I think we're all learning how to figure out what all to integrate with that. But certainly the way we envision the peer engagement process in the emergency department is that while they will be primarily for the emergency department in those acute presentations, they will also be available for those patients who are admitted who may have sequela of IV drug use, something like abscess or cellulitis, or even are not, or have been on an inappropriately long duration of opioids, and there's concern there. The full range of patients who may have substance use disorders. So we hope that as we develop the peer engagement program, that it will be for really the entire hospital.
Great. Thank you so much, Priya, for answering those questions. We have had a bunch more come in. I want to let everyone know that if you've submitted a question to us, if we're unable to address it on the live portion of the webinar, we will be in touch with our presenters following the presentation to get answers to any questions you have, and they'll be made available on IRETA's website. But at this time, I want to turn things over to Brian Haller for his portion of the presentation.
All right. Thank you very much, Krystal, and thank you, Priya, for that presentation. What we'll be covering here is the Overdose Survivors Outreach Project that is being implemented here in Maryland, and really codifies some of the concepts that Priya had brought up in the first in her presentation. So my name is Brian Holler. I'm the Special Programs Manager here in the Office of Overdose Prevention, which is part of the Behavioral Health Administration within the Maryland Department of Health and Mental Hygiene. So to provide a little bit of background, I won't dwell long on this. We all understand the epidemic that's occurring. As you can see in this graph, sorry for its being a little bit behind, but heroin use is or heroin deaths are increasing. This has continued upward throughout 2014, 2015, and 2016 in Maryland, especially given the prevalence of fentanyl. Here on this slide, you can see that, or you'll be able to see later, the breakdown of overdose fatalities as a rate. The hospitals that we're going to be discussing are within the first and third, or within the counties that have the first and third highest overdose fatality rate. So we want to see, like, where do we engage the population. The Office of Overdose Prevention and some of the other initiatives within the state and DHMH work to engage in different places. So we have collaborations with law enforcement, detention centers to provide naloxone, drug court utilization. In the field, we have a recent legislation authorized an expansion of syringe exchange. We also have some excellent outreach staff through the local health departments. But what we really wanted to do was assist in the clinical setting, and let's see why. So you can see here on this chart that the number of addictions-related emergency department visits for Marylanders has been on the rise, and these numbers have continued proportionally throughout 2015 and 2016. If you look to the bottom three that are highlighted in yellow, these are two of the three hospitals that we're going to be working with, and one that we are expanding into, hopefully. And you can just see the market increase for addictions-related ED visits. And you can see in Bon Secours in West Baltimore, it's doubled over the course of 3 years. And then here you can see the percentage of addiction-related emergency department visits for Maryland residents. These are all done through the through HSCRC, our Health Services Cost Review Commission, ICD-9 coding, now ICD-10. And the one thing I want to show is that if you look here, even though like some of them have between 5 and even 28% of all hospital or emergency department visits are addictions related, that the ICD-9 codes that we're looking at here, the chief complaints, probably are not effectively capturing all of the overdose-related admissions, because there's other reasons or other symptoms people may present with that are more pressing, like getting hit by a car, getting beat up, or that may actually have been as a result of overdose or soft tissue complaints. So what we're seeing here is, even though these rates are pretty astronomical, they're probably even underrepresenting the actual magnitude of the problem we're facing. So in a collaboration with the University of Maryland School of Pharmacy Systems Evaluation Center, what we did was we linked treatment data with hospital admissions data, or emergency department admissions data, and then overdose fatality data from the Office of Chief Medical Examiner. And in 2013, you can see that 858 individuals died of an overdose. I can tell you that number is way, way up now. But 59 of which had at least one or more visits for an overdose within the previous year. So that's 502 of that 858. And 66 had had at least one more visits for any reason in an emergency department 1 year prior to their overdose fatality. So what we see here is this is an excellent opportunity for engagement, and it actually demonstrates you know, a possible misstep for the state and for these and for local health departments and hospitals to actively engage individuals who are at great risk for overdose. And you'll see here that this is a graphical representation of this last statistic. But here's a really telling one. And that's that, you know, although most of the people, or about 60% of the people had presented with an overdose, over 50% actually had been in for multiple overdoses just in the year before their death. We're not missing just one opportunity here. 50% of the time, we're missing 2, 3, 4, all the way up to 10 and 12 you know, overdoses within a year before a fatality occurs. So clearly, you know, this is a moment that we can capitalize on, hopefully, to engage these individuals. So now we can get into the actual program, the Overdose Survivors Outreach Program. To provide a little bit of history, this is developed from a partnership between the Behavioral Health Administration, the Behavioral Health Systems Baltimore, which is a quasi-governmental behavioral health provider, or that provides behavioral health services throughout Baltimore City, and the Mosaic Group, a consultancy that has specialized in you know, emergency room and clinical setting workflow development. This all began really and was sort of built on the back of a SAMHSA-funded SBIRT grant for hospitals and FQHCs. And the way that the BHA chose to spend that money was to actually have peer recovery specialists provide the brief intervention after SBIRT was given, either universally or selectively. And this was done on primary or secondary intake. So when the triage nurse or associate was providing, you know, asking the regular panel of questions, if someone had a high enough SBIRT score, then they would be referred to a peer recovery specialist. But what we've known is that SBIRT has been effective for changing alcohol consumption practices, but it really hasn't been clear and may not be effective for opioids. So what we hoped was by integrating peer recovery specialists into the flow, that they may be more effective at you know, evincing comprehensive behavioral change. So what are the benefits of peer support services? Priya touched on some of these. It allows clinical staff to focus on somatic care. Given the level of work that is required of ED clinical staff, this is a big thing, and peers are especially effective within emergency departments, the literature shows. They can be used flexibly, meaning although I have actually found that they're being used for too many things, what can initiate an intervention with them or a talk with them is up to the hospital. So it can be a SBIRT score, it can be an overdose, which clearly wouldn't require SBIRT. Someone's brought in and has had a reversed overdose, a tox screen. And it's cost effective. You can read the quote here from the director of CMMS, but ultimately in the state of Maryland, peer recovery specialists annually with fringe are costing us about $42,000, which when you look at some of the high utilizers within the emergency departments, especially around behavioral health issues, that number can be met really, really quickly. So here you'll see our OSAP model. The goal is, the model is based around providing peer recovery specialists to overdose survivors and those determined to be at risk for overdose through motivational interviewing and behavioral health change assessments, both of which are administered by the peer recovery specialist. The peers will then actually follow up if someone's not ready for treatment and offer treatment, support services, and periodic peer support. and they'll make regularly scheduled contact in the field or via phone to provide that consistent point of contact or pathway to treatment. And the purpose of this, the goals, are to provide a pathway to treatment and wraparound services both in the ED and in the field. Because what we found is that if someone has just overdosed, they've been reversed, maybe their reversal wasn't as gentle as Dr. Mammon had said that they do it in their emergency department. So someone may be mad, maybe starting to experience withdrawal symptoms, and may not be in the best place to determine that they're ready to make a huge life change. So that's okay. The goal is to provide them with a consistent point of contact who they can call upon 2 days, 2 weeks, or 2 months down the line. They can then help them navigate the complex treatment field, get the ID, find a place that's good for them, and enroll in services. Additionally, this provides for an opportunity for things like naloxone training in the emergency department, and then harm reduction education. So not using alone, using smaller dosing and other harm reduction principles here. And then ultimately we want to enhance the collaboration between hospitals and clinics and local health departments and treatment facilities, really provide a warm handoff between all three. And then we also want to reduce, the overall goal of course is to reduce overall fatalities in Maryland. So who are our current partners here? We have BHSB, the Behavioral Health Systems of Baltimore. We have 4 hospitals that are taking part in this pilot program, Bon Secours, Mercy, Harbor, and University of Maryland Medical Center. And we have the Anne Arundel Local Health Department and 2 Anne Arundel County hospitals, BWMC and Anne Arundel Medical Group. And then the Mosaic Group, who has really been integral in helping to set up the SBIRT screenings into the workflow, and then also provide for the mechanisms for the handoff between between hospitals to local health departments when that's been required, and will really help with the pilot program that we'll talk more about in a little bit. So here is a sample workflow. So if you look in the upper left-hand corner, the referral for intervention will be triggered. This will either be through SBIRT, through an overdose that is brought in, or through someone who presents with opioid abuse-related symptoms. The patient will be stabilized and their immediate medical needs will be addressed. Then a referral will be made to the peer recovery specialist, generally by the intake or triage nurse. The peer will conduct a motivational interview, assess their level of change. If someone is ready for treatment, then the peer will provide the referral to care and assist in wraparound services. So maybe they want to enroll in MAT. That's great. Then the peer knows, all right, as a city resident or an Anne Arundel resident, here's where you can go. If they're interested in an abstinence-based program, they can refer them there. Or if they have special needs, like maybe they have a child, or maybe they need something so simple as like bus tokens to get there, the peers can assist in providing that. If somebody isn't ready for treatment, well, that's okay. The peer will take up consent for follow-up by either themselves or a member of the outreach team. So then the referral will actually be made to the outreach team, and I'll get into the differences between some of the programs in a moment, but the patient will then receive a field follow-up a day or 2 later and periodic calls to offer services. And in here you can see the jurisdictional differences. In Anne Arundel County, the peers are employed directly through the local health department, and symptoms actually trigger the referral, so an overdose or someone who presents with symptoms. And no consent is actually required to initiate a follow-up on the program, because by merely speaking with the peers the first time in the health department, they have enrolled essentially in the program to receive follow-up from the peers, because it's actually the same peers. And we have 2 peers at each facility. In Baltimore City, the peers are, the hospital peers are enrolled through the hospital, and SBIRT screening or overdose triggers the referral. And then we have 3 peers with staggered schedules that help, that help fill the need in the hospitals. And what will happen then is they will take a consent and refer overdose cases and hopefully soon, individuals at risk for overdose to local health department outreach peers at BHSB, who will then provide the subsequent follow-up. So what are some of the barriers we've seen to implementation here? One is a reorganized workflow. Fortunately for the Baltimore City hospitals, we've had the Mosaic group to help modify their workflow when it comes to intake, do SBIRT trainings for the requisite staff, for the intake staff, and also help integrate these screenings into their EMR. Then also there's the considerations of time and bed turnover. EDs are stressful and generally very high volume and highly utilized. So there's not a lot of time. There's some perceptions that someone shouldn't just be sitting there talking about their life story if someone else is brought in that needs the bed. Additionally, there are resources such as staffing, supplies, and space. Space is always at a premium. And staffing, we recently began credentialing peer recovery specialists through the state. There's an accreditation board. But finding individuals who can work in a clinical setting as non-clinicians and deal with this high stress level of work is difficult. You really need to identify clinical champions. That's another thing that we've found. You need a clinician that will explain to the rest of the staff and really help buck up conversations when someone's going through many subsequent trainings on how their work plan is going to be changed. Someone to actually demonstrate the value of the peers. Not only initially, but also as an ongoing factor throughout this. And there needs to be a shift in paradigm from somatic to integrated care. This isn't the same problem of 15 years ago. Nevertheless, there's still clinicians that see the ED as a place where you patch someone up and you send them out the door. My sister is a trauma nurse, and she always talks about how disheartening it is when you have someone who presents 3, 4, 5 times with an overdose or with a gunshot or knife wound, and you just feel like you're patching them up and sending them back out there. And so the other side of this is that peers can actually help break that cycle, but that has to be demonstrated to clinical staff who already may have some suppositions. And finally, the big one that Priya touched upon is funding. Even though peers are not super expensive specialists here, it still takes a lot of money to provide the training, to provide the resources, to provide the staffing and salaries. And so that's why we've sort of built, as I'm sure many of your programs have, just sort of cobbling things together where we can with the existing SAMHSA SBIRT grant and with some designated funds that were kindly given to us by our Lieutenant Governor's task force to combat the overdose epidemic. So where do we want to go from this? We really want to be giving naloxone kits to all individuals who come in that are at risk. And not only that, but also providing distribution in the emergency department to patients and their family and friends. This is a real teachable moment because generally, family and friends are who comes in if people don't come in alone. And this is a high stress environment to be waiting for someone who's brought back in the ED or who's in the back of the emergency room, and it can really help someone feel like they are taking part in the process if they then learn to, get to administer naloxone. We are working on implementing a pilot with 6 hospitals in Baltimore that will be initiated through BHSB and set up through the Mosaic group, and this will be done using gap buprenorphine distribution in the emergency department. This is based on some research done by Dr. Gail D'Onofrio out of Yale, which shows that individuals at risk for overdose are more likely to engage in treatment and have positive treatment outcomes if they are given a dose of bup at this time, because very few people actually can go right in front, walk out the front door and have a bed in a facility 45 minutes from there. So what gap bup prescribing does, or distribution does, is to offer an opportunity to combat potential withdrawal symptoms that someone may be experiencing at the time. And it would also be great to get dedicated outreach peers at Anne Arundel, so it looks a little bit more like the city model. That way, it won't be the same peers that are responsible for doing follow-up phone calls and field calls as that are also doing the interventions at the hospital. Currently, we have it set up so that there's probably going to be like a 3 or 6 month cutoff for when follow-up calls, keep going on, because it's difficult. Your workload just increases exponentially with each subsequent overdose or person at risk. And then expansion to other jurisdictions if funding can be found and the success can be demonstrated. This is within the first year. You'll notice there's not numbers up because the ones we've gotten are actually brand new. Our first quarter of standardized reporting just occurred, and what I can say is that when these interventions have been given, we have a 13% rate of enrollment, successful enrollment within treatment programs, which I think is really good and really significant. And this is a brand new program, so a lot of the kinks are still being worked out, but the initial response has been really positive. The goal will be to conduct a comprehensive evaluation, and we'll be doing this by linking together a couple different data sets. We want to get that HSCRC data and ultimately measure ED service utilization post-intervention. And in Maryland, we have something kind of unique. We have the HSCRC that establishes hospital rates to promote cost containment, access to care, and equity. And what they do is it's an independent organization that makes sure that the same rates are provided for the same services across the state. So this would really help demonstrate the cost savings that would occur by reducing service utilization for individuals who receive said intervention. We also want to link this with treatment data. We have Beacon Treatment Options, which gathers the Medicaid-funded treatment data. And what this would do would be to demonstrate successful treatment and enrollment and adherence for individuals who receive this intervention. We want to link this with OCME data, our chief medical examiner data, to see if there's an overdose fatality reduction or change, which we suspect there will be, or we hope there will be. And then we also want to assess the qualitative impact on hospitals' clinical staff, really assessing to see, whether having these peers there really does help take perceived burden off of some of the nurses and doctors and NPs in the ED. We think some of the outcomes are going to be reduced readmissions, greater adherence to medical care, increased number of patients in treatment, which we were already starting to see, increased amount of naloxone distributed, so hopefully reaching that critical saturation point in the community, reducing the reduction of clinical staff time spent on behavioral health issues, which is always a big concern in the ED, and then increasing clinical and support staff morale, and ultimately the reduction in overdose deaths. So before I wrap up, I just want to tell a quick story. And I was at a conference last year, and I bumped into an EMS director who was a former field EMS, and he was telling me about how he had run into someone at that conference that he had actually responded in the field to many times to reverse an overdose, like numerous times. And he was surprised to see the gentleman there, and when he asked him, what he was up to, he had actually opened a few sober living homes and was getting a space for a treatment facility up and running. And the EMS just said, like, wow, that's amazing, but what is it that made you make this change? And the guy said, well, I overdosed like 8 times. Like, I'm not an idiot. And I think that response really captures the fact that, there are many opportunities to engage someone, and it can easily be disheartening, especially for emergency and first responders, to think of this as a real uphill battle. And although it is, there's many opportunities to engage individuals along the way, and it's all about trying to identify those successful models and really help build upon them to not only provide the support to the individuals at greatest need, but also to those working in the clinical settings that are helping save these lives as well. So thank you all very much. If you have any questions, please ask now, or you can reach out to me via email.
Hi there, Brian. We've had some questions come in. Thanks so much for your presentation. The first question I have is, how are you able to get identifiable data from emergency departments to match fatality data?
So currently the easy part is the OCME data, which we currently get. What it's taking with the data coming from hospitals is consent from the hospitals for individuals who have received these interventions. We can get the incident level HSCRC data and OCME data, but the rest of it needs to be coming to us from hospitals under the public health authority that the DHMH currently holds. So our AG's office our Attorney General's office has vetted this and has signed off on it, but it's an uphill battle to get this information, to obtain this sensitive information containing PII from the hospitals. But the initial, we've had multiple hospitals already sign on to do this. And ultimately, it's because this is the way that it's going to demonstrate to them the cost savings. This is like cobbled together from a bunch of different funding sources, and grants run out. So we really want to prove that not only is this sustainable, but it's also in other hospitals' best interest. That's why some of the consortiums we've been working with, like University of Maryland and MedStar, are really excited to take part in this evaluation, because it could be expanded throughout their system and greatly reduce service utilization and expenditures.
Great. So the next question is, what is the reasoning behind 2 versus 3 peers at the 2 facilities mentioned? What kind of feedback have you gotten from peers who are working a shift on their own? Have there been any comments about any burnout or lack of support or anything like that?
So that's a great question. And ultimately, why 2, why 3, why not around the clock? It just comes down to funding. That is 100% of it. We would love to offer 24/7 services, but the money is just not there. The reason that we stagger them in 8-hour shifts in the city with 2 hours of overlap is to help provide support to each other and prevent that burnout. That's similar to what happens in Anne Arundel. I think it's a 4-hour overlap there. But to give the peers time to speak to each other about, their cases, what they're working on. And, burnout is something that happens in emergency rooms. I was a patient advocate in one, and I can tell you, I was I was certainly, fell prey to it at times. So it really takes resilient staffing, proper training, and a real understanding of, the difficulty of the position. We're having a peers in hospitals forum here on November 30th, where we've invited all the peers working in hospitals throughout Maryland. And we're really using it as an opportunity with 3 goals. Like, number 1, for them to develop an informal network of support among each other. Number 2, for us to find out what's working and what's not. And 3, to set up an information sharing between these peers and the state. So, we can really help provide them with resources and services that would make their job easier and hopefully prevent some of that turnover.
All right, the next question is, do you know of any other states who are doing overdose survivor outreach work?
Yes. Some of this was based on the Rhode Island model. I think there are a couple other states that are doing this as well. But what everyone's really kind of waiting for is a real comprehensive proof of concept here. And I know there's a bunch of states working on it. There was actually just an article on CNN about peer engagement in hospitals. I'd recommend all of you check out. And I am going to be reaching out to some of the other states there that are doing this that we don't know about.
Great. I think we've had a couple more questions come in here. What behavioral change theories does the OSOP program work from? In other words, what markers determine a patient's readiness for treatment that prompt the peer to facilitate that process?
Sure. So, actually there isn't one unified concept, because the Overdose Survivors Outreach Project is sort of a loose collaboration between these hospitals, local health departments, and ourselves. So it's not like saying, hey, we're using the trans theoretical model for this, and that is the only stages of change model that we're using. Different peers bring different skill sets to the table, and it's one of the things that's a little bit unnerving, but also really positive about the entire peer recovery specialist position. Much like medicine, it is not an exact science, so we really let the peers develop the interventions that are most productive for them, and then that's why we're really trying to do assessments from the peers to see what's working and what's not. So it's not a 100% scientific approach to this.
Great. Thank you, Brian. We've also had a bunch of other questions that have come in that I don't think we're going to have time to get to today, but I will send those out after the webinar and they'll be posted to the website. At this time, I'm going to turn things over to Dr. Jean Bennett to make a few closing remarks.
Thank you, Krystal. Can you hear me okay?
You sound great, Jean.
Okay, thank you. So I am really impressed, as I thought I would be, with the presentations today, and I just wanted to give you a little framework around it that I was unable to do at the beginning. In Region 3, as in the other regions, our regional customers really drive what happens and how we focus our activities. And in Region 3, it was really our colleagues from the Opioid Overdose Prevention Regional Collaborative and the Behavioral Health Workforce Collaborative that came up with the ideas for this webinar series. And, you know, that is really what makes me tick. But I think the bulk of the work and the real kudos have to go to the people who were involved behind the scenes, and Priya and Brian for all of the work that they've done. But I think the webinar is just a little snapshot that is a culmination of years and years of preliminary trend analysis and incremental steps of progress that they have both made as champions and role models for all of us. Resource-wise, we could have another entire webinar just on resources that are available through SAMHSA and other federal divisions. But I think I would just say, if there's anything you want to know about what SAMHSA has been focused on related to peers, if you start at samhsa.gov, it will lead you to that information. Also, your regional administrators across the country and your regional addiction technology transfer centers, which are funded by SAMHSA, and your national addiction technology transfer centers, such as the expert ATTC, who provided the most support through Krystal's and Holly's work. You know, we are all available for you afterwards if you have questions, and also I'm sure Priya and Brian will be very generous with their time, as they have been already. This conversation today really fits into a larger solution set to be described in webinars 2 and 3 on November 3rd and 9th respectively. And I think I'm stealing Krystal's thunder a little bit, but next week, I'm so excited about it, Krystal, I have to mention it. Next week is the Pennsylvania Warm Handoff and West Virginia 24/7 referral models. And then on the 9th, we're going to talk about health system-wide sustainable peer programs that we're very fortunate was developed in the state of Delaware at Christiana. Finally, I just want to really say thank you to Dr. Mayman of Jefferson Hospital in Philadelphia, and who also has served for years as part of my regional medical schools group, working on core competencies and other priorities, and also Brian as part of the Office of Overdose Prevention in Maryland, and the huge team in Maryland that has done so much work to support what folks are interested in the region. I don't want to forget thanking the Region 3 Addiction Technology Transfer Center that was also in support of this and in coordination with the expert ATTC. Also, a quick shout out to Sagan Katema from my office, who has been supporting me through all of this, and also all of my colleagues who forwarded the webinar opportunity to help market it, including the regional director, Joanne Grossi, the Office of Addiction, the Office of the Assistant Secretary for Health, Regional Health Administrator, Dalton Paxman, and then CMS, and I had colleagues from all of the states telling me that they were referring this out to other people, so which is why we had hundreds of people on this webinar today. Finally, I just want to let you all know that if it weren't for the SAMHSA leadership in the Office of Policy Planning and Innovation that gives me the flexibility to be responsive to what you want, I would not be able to have the flexibility to do things like have a webinar based on ideas bubbling up from our regional collaboratives. So, you know, I think that those are really my closing comments. I'm very, very excited about the next 2 webinars, and that others will access the archive of this one. And I guess that wraps it up for me, Krystal.
Thanks so much, Jane. I want to thank everyone who's been on today for your great questions, and I want to thank our presenters for such a great webinar. At this time, I'm going to briefly go over our evaluation and continuing education instructions. You'll be receiving a few emails from us following this webinar. In these emails, there will be a link to the recording of the webinar, as well as a PDF version of our presenter slides. Also included in the email is a link to our evaluation. Our grant evaluators are required and pleased to collect feedback from all event participants. Completion of this evaluation is critical to maintain our funding and continue to provide quality education and materials to you. Your participation is appreciated, and the evaluation should take no more than 2 minutes of your time. Immediately following the evaluation is a request form for a certificate of attendance or NADAC and PCB CEUs. Should you choose to skip the evaluation and proceed directly to the CEU request, leave all the answers blank on the evaluation. Again, we want to thank you for your participation today, and if you have any questions, don't hesitate to email us at info@ireta.org.